So I think there's a very interesting element of what we have found within our Bristol experience of Kawasaki disease, which is for those patients previously with undisclosed Kawasaki that present to us acutely, and particularly in my practice treating patients with acute ST elevation myocardial infarction. We've found that in the younger cohort of patients presenting with MI, that there is a greater incidence of aneurysm and ectasia. And we've done some retrospective assessment of a patient cohort that have undergone angiography under the age of 50 and shown rather concerningly that our colleagues are not so good at highlighting the presence of ectasia or aneurysm. Now, it may be that actually it's because those patients were presenting in a very acute manner, in the sense that they presented with either abrupt occlusion or in the setting of a non-ST elevation infarction, that the priority was that acute care. But the failure to acknowledge the presence of ectasia or aneurysm potentially jeopardizes the ongoing care of that patient and trying to minimize the chance of them returning with a further occlusion. And so really we need to somehow get the message out there that patients with significant aneurysm, particularly the giant aneurysm greater than 8 millimeters, that we need to then be protecting them in addition to the standard care of antiplatelet therapy, but actually then adding anticoagulant therapy to assist in their risk management. At present, I think there's a real concern about the potential for under-assessing patients that present in an atypical manner. And certainly, there is a concern that the younger patient presenting with atypical chest pain that has really none of the standard classical risk factors for coronary artery disease, be it high cholesterol, smoking, high blood pressure, that the likelihood of them having a coronary event is incredibly small. But clearly the prior history of Kawasaki disease does place that person at greater risk of a coronary event. And that may be, in fact, even in the absence of having a persisting aneurysm. So the inflammatory nature of the Kawasaki process could result in abnormal functioning of the coronary vasculature. And so we know, and certainly from our follow-up of patients into the adult clinic, we see that there are patients presenting with atypical symptoms that may represent the coronary vasculature having a greater tendency towards spasm, or there being some other unusual kind of manifestation of the inflammatory effects of the coronary inflammation. And so I think we have to be very clear that Kawasaki is a diagnosis that needs to be considered in those atypical presentations. And in some ways our recognition may become easier in that the guidelines over the last 5 to 6 years have changed in the way that we should be managing patients, and there is a greater tendency now towards undertaking non-invasive coronary assessment. And so I would hope that if undertaking a CT coronary angiogram, we see that there are abnormalities in terms of vessel thickening or ectasia or aneurysm again, that diagnosis of Kawasaki might be considered. How we then go on to further risk stratify and to follow up these patients, I think is challenging, and there is some guidance coming from other areas in the world where Kawasaki is more prevalent, so particularly from the San Diego group and from Japan. And here in Bristol, we're trying to instill those guidelines with a view to annual assessment with ischemia testing for our patients. And for those with aneurysm, then clearly there is the need to continue to monitor their coronaries for the evolution of either thickening of the coronary arteries or increasing of the aneurysm.